Good evening. I'm Dr. Kurt Lundberg. Like I said, I'm an interventional pain specialist. I do, a lot of injections. A lot of you have probably heard about epidurals, ablations, kind of the more basic stuff that a lot of us do. But today is really about spinal cord stimulation. Certainly a lot of people have never even heard of this, or they've heard of the word but don't know what it is. So that's what kind of prompted me to do this talk tonight. So. Disclosures, I don't have any. I don't work for any of these spinal cord stimulator companies. I don't get any financial reimbursement for talking about this. This is just kind of an educational and informational session. So tonight we're going to talk about what exactly neuromodulation is, which is kind of an umbrella term for spinal cord stimulation, how it works or how we think it works, who it is for, what type of patient's pain responds well to this type of treatment, an overview of what a spinal cord stimulator trial is about, how it works, how long it lasts, and what you could expect from one. And at the end, we'll review some evidence-based medicine trials just to show that this does work. It is supported by high-level evidence and trials. So, like I mentioned, neuromodulation is kind of the umbrella term for spinal cord stimulation. It is defined as the alteration of nerve activity through electrical stimulation to specific sites of the body. And this has been around since the 1960s. Certainly spinal cord stimulation falls under this type of technology. Spinal cord stimulators were approved by the FDA back in 1989. Currently, they're probably implanting anywhere from 30 to 35,000 of these a year worldwide, so it's definitely picking up steam. But the technology itself is used for a lot of different things, not just spinal cord stimulators, right? So there's peripheral nerve stimulators. This is, you think about people getting stimulators on the vagus nerve for chronic depression. There's deep brain stimulation. These are people who have Parkinson's disease, people who have epilepsy, people with severe headaches. They actually put the stimulators inside the brain to help these people cope. And, on maybe a more lower end of the spectrum, just a TENS therapy, transcutaneous electrical nerve stimulation, which many of you may have at home. You can buy it on Amazon. It's the little pads you put on your skin. It's the same thing, right? Using electrical signals to inhibit nerve activity. And all that kind of falls under this umbrella term of neuromodulation. So, the next thing you'd think about is, well, how does it work? How does this actually happen? And it's a tough question even for someone in my position, because they don't 100% know. And it all started back in the 60s when they came up with this theory called the gate control theory of pain. They found that stimulation blocks the transmission of pain signals in nerves. And I think things get kind of tough when you start thinking of when you don't know how it actually works. You end up with a lot of different companies making these stimulators, and they all have different marketing techniques and different ways that their stimulators work or that they say they work. And is it the type of frequency? Is it the way the pulse is? Is it the type of nerves that they're stimulating? And they all work. And I think that's why there's a lot of variability in how patients respond, because every one patient, their pain is originating from different sources, and thus different technologies work a little bit better. But on a kind of a more global or overall look at it, it does work, and there's certain patients that respond very well regardless of what system you use, what company you use, what frequency you use. You're always going to respond. So there's definitely kind of, when you get into the weeds of it, there's the details get kind of tough. But overall, the stimulator has been well proven for, that's like 50, 60 years. So again, like I said, everyone's pain is different. So you think of like what pain is, and in general, we divide these into two broad categories. So there's nociceptive pain. This is like a dull, throbbing pain from tissue injury. So you think of like inflammation and swelling. You think of spraining your ankle. You think of a scalpel, cutting open your skin, like tissue trauma. This type of pain typically responds pretty well to just anti-inflammatory medication, opioid pain medicine, and this is not the type of pain that most people are treated with spinal cord stimulators, because typically this is a tissue-related injury. It typically heals well and responds well to pain medicine. So the other broad category you talk about is neuropathic pain. So this pain is typically described as a burning, shooting, pins and needles pain, and is typically secondary to some sort of nerve damage. This type of pain doesn't classically respond very well to anti-inflammatories. It doesn't respond to opioids very well. There are some nerve pain medicines like gabapentin and Lyrica you've heard about, and it does work reasonably well. But certainly when you sever a nerve or you have a damaged nerve, that's not something you can typically operate on. It's not something you can typically replace like a severely arthritic knee. So this neuropathic pain was a real tough thing to treat for a long time until the stimulator stuff got a little bit got ahead of it. So that's the theory behind it. Actually, before I go on, I got this picture. It reminds me when I talk to patients about this in the office is, when they think about how this theory works is, if a child gets a cut on the hand, one of the first things they do is they hold it, they rub it, they rub it, and somehow it makes it feel better, because if you stimulate all the nerves in your hand, it can kind of drown out the ones that are causing pain. There's only so many signals that can get up into your spinal cord and up to your brain for you to perceive this pain. So you can kind of drown it out. And that's a good way of thinking of how these stimulators work, right? It's not fixing anything, it's masking pain, it's drowning it out. You're putting these leads in your back that are essentially inputting white noise and drowning out the pain from whatever nerve it's targeting. So who is spinal cord stimulator for? So just like I just mentioned, the best patients for spinal cord stimulators are people with nerve type pain, right? So I guess the most classic reasons we do these are for failed back syndrome and post-laminectomy syndrome. These are patients who have had back surgeries or neck surgeries. There's obviously risks in any type of surgery, and when you're working in the spine, one of those risks is damaging a nerve, or possibly there's scar tissue that starts developing in where the surgical site was. Sometimes the surgery went just fine, but the nerve was pinched for so long that it got damaged, and just because you unpinched it, it's still, it's certainly the pain is improved, but you still get left with this residual neuropathic numbness, tingling pain in your legs. That's the classic post-laminectomy syndrome. So laminectomy is typically something they'll do when the patient has spinal stenosis. You're pinching the nerves, you get a laminectomy, you unpinch the nerve, the pain improves, but those nerves were still pinched for so long that there's this residual pain left over, and stimulators work really well for this. Other diagnoses you think about, complex regional pain syndrome, probably not a diagnosis most people have heard, but if you're a patient who has this, you certainly know how hard it is to treat. Stimulators work really well for that. An older term for CRPS is reflex sympathetic dystrophy. RSD is also another term kind of for the same thing. Causalgia, again, kind of a fancy term for a damaged nerve. Phantom limb pain, you have people with amputations who have nerves that were severed. Again, spinal cord injury follows right along with that. Arachnoiditis, kind of more unique thing, but certainly goes back to damaged nerves and inflammation back in the spine. Postherpetic neuralgia is kind of patients who get shingles, those nerves get damaged, and even though the shingles and the infection is gone and cleared, you're still left with this residual nerve pain afterwards. Multiple sclerosis is a damage kind of globally in your spinal cord and your brain, and damage to the nerves. Chemotherapy-induced neuropathy, so toxins in your body causing nerve damage, usually in the feet or the extremities. That's a tough thing to treat if medication isn't working. And then, pelvic floor surgery after surgery. Again, a lot of big surgeries, a lot of nerve damage. And it's tough because, I understand that when you cut open tissues or muscles, you're cutting nerves. That's more of a localized thing that you do expect to heal. But if the pain continues for 6 months, a year, years later after a surgery, you start wondering what else got damaged in that surgery. So, like I said, the spinal cord stimulator is, this is kind of a more advanced thing. This is not something that you just, I got a little pain for a couple months, I need a spinal cord stimulator, right? This is a long road. This is kind of one of the last steps that you would expect as long as surgery is not indicated. So, the first things you start on the continuum over here, right? You don't want to skip 5 steps and do something very invasive when something much easier could have worked. So, physical therapy is always one of the first places we start. Medications, You're going to try all 4 types of pain medicines that exist. You're going to try anti-inflammatories. You're going to try muscle relaxants. You're going to try the neuropathics and maybe low-dose opioids if it's appropriate. If your pain is controlled on medications, I'm not sure you need to go far enough to get a stimulator or have something implanted in your body to control your pain. There's much less invasive injections, steroids, epidurals, nerve blocks, radiofrequency ablations. Certainly if you're a chronic back pain patient, you've probably had or at least heard of many of these injections. So you start there, right? These injections, if they don't work, there's no harm, no foul, right? It's over, it wears off, it didn't work, you move on. Stimulator is kind of the next step past that. Like I said, if something easier works, then go with that. And then surgical consultation. Patients who have spinal stenosis, patients who have a spondylolisthesis or a misalignment in the spine. These are surgical consultations. These are surgical cases. The stimulator can block the pain, but that's not the fix. I would say the stimulator is more for patients who don't have a surgical solution to their problem. A lot of times my patients, before we go and start doing this, I have them see a surgeon just to make sure that they don't think there's anything to be done, or possibly they've already had back surgery and the surgeon thinks that it's too risky to go back to the operating room. So again, don't think that this is one of your first line treatments for chronic pain. This is one of the last type treatments after many other conservative and less invasive treatments have been failed. So who are the good candidates then? So, patient selection is a big part of all of this. So again, we'll go back to neuropathic pain. Pain is present 24/7, right? It's always there. It's not like it happens once a week. You're not going to have something implanted in your body for something that just flares up every once in a while. Pain is not primarily mechanical, and when I say that, I mean, again, like a spondylolisthesis. If you have a misalignment in your spine, you're going to have to bring that back in alignment to really get good pain relief. I don't think a stimulator would be strong enough to really overcome that. Or if you have, a knee replacement that's unstable and no longer aligned, you don't just put a stimulator in to mask the pain in the knee. You go to your knee surgeon and you have it revised. Certainly, like patients who are not surgical, if you've already had a back surgery and they don't think going back in is going to be helpful, or it's too risky, or they can't, feel that it's going to be a good fit for you, stimulator is an option. Patients who have untreated depression or drug addiction, obviously this adds, drug addiction can cause a lot of problems and alternate care treatment plans. Untreated depression, right, chronic pain and depression go hand in hand. It's kind of like the chicken or the egg type thing. So certainly, if there's a large amount of depression playing into the psyche of the chronic pain patient, that should be addressed before you start doing stimulators. No medical conditions that would preclude implantation. So when I say that, I'm talking about people on anticoagulation medications that cannot be stopped. If you recently had a heart attack and you had a stent placed, a lot of the cardiologists are not going to allow you to have a stimulator placed within the first year or so, just because they don't want to stop the anticoagulation. You also think of pacemakers. That's a conversation between the pain doctor and the cardiologist to see if they can make it work. It doesn't mean you can't have one, but certainly a little bit more careful when you start putting electrical things next to your pacemaker. And an insurance that covers the trial and implant. And when I say that, I mean, you need an indication for this. It's not, like I said, you come in and say if you have back pain for a couple months, I don't really know if a stimulator is the best treatment plan. You're going to start at the easier stuff with physical therapy and maybe some pain medicine as needed. On the flip side of this, who would be the bad patients for spinal cord stimulator? So like I said, mechanical problems. If there is a surgical solution, you're probably better off getting the treatment than masking the pain. You think of fibromyalgia is a big thing I see a lot, but the fibromyalgia pain is so diffuse and through the body that you're not going to really be able to cover that just by putting a couple leads in the spine. The spinal cord stimulators are very specific. You program them to essentially inhibit very specific nerves. So if you got pain in your legs or your back, that's fine. It doesn't have to be in one spot in your leg, but it's not going to cover your whole body or anything like that. You can put the stimulator in your neck to help with neck pain and maybe pain in the arms, but it's not going to cover your whole body. So that's a little different. Other things I think of, dementia, cognitive issues may not be the best fit for patients who have those issues. Let's see. So here is an example of what a spinal cord stimulator looks like. So on the, I guess it's on the right there, you have, that's the IPG, which is called the internal pulse generator. That's the battery, and that's kind of the brains and where you do all the programming. And then they're connected to wires that go up, and then leads at the end. You can see that big picture, there's about 8 contacts there. And those contacts, that's what's doing all the work, right? So you have the contacts go into the spinal cord, kind of exactly like an epidural. You know, you do an epidural, you put steroids back around the nerves, it's going in the same space. It's the same space that we do labor epidurals for our pregnant patients who need labor epidurals. This is the same space. Instead of, you know, injecting numbing medicine to help the laboring patient, this is an electronic device that goes up the spinal cord and inputs, you know, electrical signals to help mask the pain from below. So if you see that x-ray there, you can see how high these electrodes are. These electrodes don't go over your low back when you have low back pain or if you have hardware in your low back. They go relatively high up, kind of, you know, mid-thoracic area, and then the wires come all the way down, exit the spinal cord, and go into your pulse generator. Now that battery can be anywhere. You know, you can put it, some docs will put it down more over the buttocks area. Some people put it kind of like in this picture, somewhere between the bottom rib and the top of the pelvis. There's a nice little spot there. But again, you know, that's something to talk with your doctor where you think would be the most comfortable place to put it. You know, you can put it on the right side, you put it on the left side. This is something that goes underneath your skin, kind of like a pacemaker. And certainly there's a little bit more flesh in the back. You know, a lot of pacemakers will stick out quite a bit depending on the patient's habitus, but in the low back, you know, there's usually a good amount of muscle and fat and tissue back there that, you know, there might be a little bump, and you can definitely see it if you had your shirt off, but I don't think it's gonna be, you know, it's not hanging out, it's not gonna obstruct what clothes you wear or anything like that. Certainly wouldn't wanna put it on the belt line. But it is under the skin, and the whole thing's enclosed, so once it all heals up, you know, you go swimming, you take showers, this thing's on 24 hours a day. So, let's see. So, let's talk about a spinal cord stimulator trial. So that is one of the very nice things about a spinal cord stimulator is you can try it before you buy it. Right? You're not going to go in and get cut open and have this thing placed, you know, permanently and hope that it makes your life better and controls your pain. You do a 5 to 7 day trial where you put the leads exactly where they need to be. In that picture, you can see that is in the epidural space, that is inside your spinal canal, well below your skin, and that's what's doing all the work. That's what it's inhibiting the nerves in your spine and controlling the pain. The leads will go out of the spinal canal and out of your skin, and then the battery is taped on your low back for about a week. You just try it out and see how it goes. I mean, we can reprogram it, we can turn it up, you can turn it down, you can push it to the right, the left. I mean, you can do quite a bit in that 7 days to really see if this is gonna, you know, be a success or a failure in your case. Most trials are considered successful if you get 50% pain relief or more. Maybe you lose less pain medicine, sleep better, better functionality, more activity. You know, these are kind of the big things we look for to see if this is going to, you know, be a success or not. The IPG is, like I said, on top of your skin. The leads are going in and underneath. If it ended up being a successful trial, at the end of the 7 days, you're going to remove all of this no matter what. Right? There's a huge infection risk when you have these leads into your skin for a week. So regardless of whether you're happy with it or not, at the end of the 7 days, you pull this out of your body and you go back in under the OR, and that's when you have the surgery, which is essentially maybe a 2 or 3, you know, maybe a 3-inch incision in your low back just to get that battery underneath your skin. Well, I guess all STIM trials will require a psychological clearance before you do this trial. It's a one-time visit with a psychologist, and a lot of that, and this is kind of a nationwide thing, it's, you know, you have to do it. And sometimes I feel bad asking some of my patients to do it because I don't have it. They think I'm concerned about their psychological state, but it's really to rule out a lot of the depression that we talked about, make sure that's not too big of a factor in the chronic pain, you know, make sure that the pain medicine isn't being abused, and to set realistic expectations of what this is going to do. I mean, it doesn't make you Superman. It doesn't mean that if you stub your toe you're not going to feel anything, but it's to be reasonable about what to expect. Here is, so like I said, during this 7-day period, most physicians will have you take antibiotics, although it's not 100% necessary. Mostly it's just a preventative in case there's any infections developed. The trial itself, there are no incisions, there are no staples, there's no stitches. This is just done with needles and takes probably 30 to 45 minutes in most cases to get done. It's usually done in one of the procedure centers, so it's not done in a hospital. The trial is not done in the OR. It's in the same place that a lot of you have had injections in the past, your epidurals, your ablations. That's where the trials are completed. If you end up going to the permanent placement, that's done in the hospital in the OR. And like I mentioned, at the end of the week, whether it's a success or a failure, the trial is removed mostly for that infection risk. So this is a picture of kind of what it looks like. So on the right there, that's the procedure center. Again, where we do our epidurals or ablations. It's all kind of done in the same spot. It's done under a live x-ray machine. That's what that big C-arm is. So we can watch the leads go in and follow them up your spine to make sure they're going in the right spot. And then on the left there that's where we tape the battery on the back for a week. So you can see, you can kind of make out where the leads are. You can't really see where they enter the skin, but under that white part, that's the battery, the IPG, and we just tape it across your low back for a week just to see if it works or not. The week after, you remove the leads in the office, so you don't have to go back to the procedure center to get the leads out. We just go ahead and in the office pull them out. You probably pull out within 10, 15 seconds, and then you kind of decide whether or not you want to proceed with the implant. So that's that picture there. So the implant, I won't talk too much about that. It's getting a little bit further than what we're doing, but this is not a back surgery. We are not going in and revising any type of past hardware, nothing. It takes about an hour or two to put it in the OR. The IPG is controlled usually by your phone or a little remote through your skin. And it's not uncommon to have these stimulators reprogrammed every once in a while. We'll talk a little bit more about lead migration, but the longer those stimulator leads are in your spine, you develop scar tissue around there, and that helps keep the leads anchored in your spine, but it also adds impedance. So sometimes I see patients say, oh, it's been a year, my stimulator hasn't worked in a while, I don't use it anymore. I mean, you should, let your team know that this is happening, because they can go in, they can boost it, they can change the settings on it, they can reprogram where it's being stimulated, where in your body, how high, how low, legs or back. There's a lot of things they can do to fix it just by programming it differently. Doesn't mean that you have to go have it opened up again or anything like that. So risks, there's always questions about what's going to happen there. Obviously, with the trial itself, I mean, anytime you puncture the skin, whether it's a trial or an implant, there is always risk for infection and bleeding, which is why we have the antibiotics on and things like that. That's kind of like just basic OR protocol. But lead migration is probably the most common complication. So when I talk about lead migration, what that means is, we put these leads up in your spine and we program it to cover your nerves in a certain way. So if those leads get pulled down, right, we're not stitching these leads inside the spine. We're hoping that they sit there long enough that there's some scar tissue develops to help hold them in place. That typically takes maybe 3 to 4 months to really, scar in. After about 3 or 4 months, it's not very common for these things to move, and your lead migration rate really plummets. But certainly it's something I have a discussion with my patients. People get them implanted or in the trial, the pain's better, they feel great, they want to be more active, they want to go to the gym, they want to go hiking, they want to do this. And I certainly don't want to scare people and say, you just need to sit in bed for 6 months or 4 months until this, scars in. But you don't want to go jet skiing, you don't want to go run, a jackhammer or, anything too extreme, because those leads can get pulled down. And when they get pulled down, it's not dangerous, it's not going to cause any issues, but you lose where it's getting programmed and you lose the target nerves, so you may not be able to cover your pain as well. It's not going to, it's not going to damage anything if you get pulled down. You're not going to get paralyzed or anything like that. It just won't be effective anymore. And sometimes you have to go in and revise these and kind of push them back up. The other big topic is MRI restrictions. Every company has their own MRI compatibility to some degree. A lot of that depends on what you want to MRI, how you want to look at it, how, I guess, strong, they call it Teslas, and what device, what manufacturer device you have. So these are good things. If you, let's say you have epileptic seizures and you need a lot of CT or MRIs of your brain, and you're going to have a stimulator placed, you certainly want to start looking about what manufacturers are okay to do head MRIs when you have a stimulator in place. So there's a lot of variability there, but certainly something to kind of keep in mind in what you think you're going to need in the future. So let's get a little bit into some of the evidence, just so you know that this stuff has been validated quite a bit over the last 10, 15, even 20 years. So for those of you who have heard about spinal cord stimulators 10, 15 years ago, that was basically a lot of tonic stimulation. And the older versions of this, even before my time, before I started doing these, the stimulators would leave a constant paresthesia feeling in the legs. So if you had this in, the stimulator would be on, it would help the pain, but you would always kind of feel a certain sensation in the legs. And that was very classic, the tonic stimulation. Some patients liked it, they felt like it was working. Some patients couldn't stand it and thought it was so annoying that it was better to have the pain. A lot of that has been replaced with a lot of these new wavelengths. So, by and large, I don't think that's an issue anymore. You should be able to get a stimulator placed. They can program these pretty specifically to target where your pain is, and you won't really have pain occur in other places. So you'd have a patient who have horrible right leg pain after they did a back surgery. They go do a stimulator, the right leg pain's better, but now they have a constant paresthesia feeling in both legs. So it wasn't really ideal. That's not really a problem anymore. So I know a lot of the patients you hear of, you'll hear of burst technology, you hear of the high frequency, some of the newer studies coming out and the newer manufacturers are coming out with stimulators, concentrating on the support cells of the nerves, like the glial cells. And again, this is a lot of the different manufacturers, and each one kind of has their own thing that they've been targeting. So, I got one of the manufacturers, is almost 1,000 patients and 20 studies over the last 10 years, right? These are high-class studies, randomly controlled, placebo-controlled, at big centers, and the results are fantastic. You're talking 90% pain relief in the vast majority of patients. So tonic stimulation, as you can see, just very simple, one burst, just trying to block some of it. Now they're doing, burst stimulation tries to mimic the way that the nerves in your body talk normally. And so they're trying to replicate that, that's how they get away with some of the paresthesia feelings. It's how they kind of targeted therapy. So, let's see. Here's, so this is kind of a big study. It was kind of a review, I guess, that they published in 2016 in Pain Physician, which is one of the really big journals. Again, I'm not going to get into the details of a lot of studies, but this is 6 studies, 3 trials, efficacy and stimulation trials, and they stated that there is significant level 1 evidence of the efficacy of a spinal cord stimulator in a failed back surgery. So someone who has had a laminectomy or a back fusion, level 1 evidence that this is an appropriate therapy, as long as a lot of the other treatments have failed in the past. So that was in 2016, a big review study. More recent studies. Here's a 2019 study, followed 400 patients for 2 years for neuropathic pain, right? So very specific. They had 89% of their patients report greater than 50% pain relief, 91% or over 90% happy with the treatment and would do it again. I put that study into focus neuropathic pain, right? Those are really good results. So patient selection is key. If you picked a bunch of patients who had mechanical back pain because they have a misalignment in their spine, I don't think you would see those type of numbers. So they really focused on 400 patients who had very legitimate and specific nerve pain. They responded very well. 2021, this was a study published this year. They followed 200 patients for 2 years who had already had back surgery 3 years ago. They tried multiple waveforms, multiple different manufacturers. Again, pain scores dropped 8 to about 4.7, about half after a back surgery. So again, multiple waveforms. I go back to, a lot of patients have a lot of questions about what company they should pick and which one's the best, right? So every one of these companies and manufacturers have studies that kind of focus on specific patients, right? So a patient who has back and leg pain and comes into me and was not a surgical candidate and wants a stimulator, I would treat differently than a patient who comes in who says they only have back pain, right? So there's the studies start showing minor advantages of different manufacturers based on how the patient presents. But again, if some of the more classic common neuropathic pain patients we see, I would imagine every manufacturer can respond very well to nerve-type pain medicine after a surgery. This one was an older study, but 2005, right? 2005, they were still having studies about all this. And this is by Dr. North, kind of one of the milestone studies published in the neurosurgery publications, a spinal cord stimulator versus revision spine surgery. So this was a randomized controlled study of 45 patients who still had leg and back pain after a back surgery. They were all cleared for a revision surgery. So they were all supposed to go get surgery, and they randomized them to either actually go have the surgery that they were planning on doing or do a spinal cord stimulator, right? So you think of these patients, it's pain, right? This is not, a screw broke loose. This is not that they see a brand new disc protrusion and something needs to be revised. They're trying to treat the pain, and whether they got a stimulator or a revision surgery. So 9 of 19 patients who had the stimulators reported success. That was about half. It's pretty good in a difficult patient population. And reoperation was successful in 3 of 26, which was about 11%. So they actually allowed a lot of the patients who had the revision surgery to cross back in and get the stimulator afterwards. But it just shows in 2005, these things were already starting to be topics like, do you revise, do you do a stimulator? And certainly it is an option and a discussion to have with your doctors and your surgeons and what might be the best for you, and whether or not the surgeon is actually feels he can go fix it, or if he's just trying to clean things up and he's not really sure if it's going to work or not. Unfortunately, we are not quite in the age where they would recommend a spinal cord stimulator for, let's say, just chronic back pain, or maybe there's nerve pain and we're not really sure if surgery is going to work. But if you haven't had surgery yet, we're not quite in the era where they would recommend getting a stimulator just because the epidural didn't work as well or last long enough. I certainly see that maybe being in the future, and there's already studies kind of going that way. Like, why have a surgery or a lumbar fusion first when you can at least try a stimulator for a week and just see if you're happy with it, and maybe you can prolong this as long as it's not dangerous. We're not quite yet at that, but the studies are getting done right now. So again, let's go back, because I get a lot of questions about the manufacturer. There are a lot of different options. The paresthesias, that's kind of the old tonic stuff where you would always feel it. Essentially, all the manufacturers are paresthesia free at this point. So that's kind of a lesson topic. Different wavelength technologies for different types of pain. Do you have back pain? Is it back pain only? Is it back and leg pain? Where is the pain? So high frequency burst, DRG, is it only in one extremity? Is it very specific? These are the type of things that we doctors start thinking about when we start choosing which way we're going to go. Battery options are typically more of a patient decision, right? You want a rechargeable battery, they typically will last longer because you can just recharge them. If you get a non-rechargeable battery, it's nice not to charge it every couple days, but you'd have to understand that maybe in 5, 7, 10 years, depending on how your settings are, you might have to go back and have the battery changed out. It's not a big deal. It takes maybe a half hour, but again, you got to go in and get cut on and have the battery changed out. Some of the newer stuff is coming out on the market now, have external power sources. So That means that the leads are underneath your skin, wherever your pain is, whatever nerve they are targeting, and you have an external generator that, maybe your pain only really bothers you at night, but during the day you're active, you don't notice it. So during the day, you don't have a generator. There is no battery underneath your skin. The leads are there, but they're not being used. And then at night, you maybe strap it on, or they have different devices to hold it next to it, and that's when it turns on. And then overnight, you have that relief. And certainly MRI compatibility is something that we always think about, and what your other comorbidities are, and what is the likelihood that you would need an MRI in the future, depending on where it is. Again, I can't stress enough how these are the conversations you have with your physician about, which one's best for you. So again, to kind of wrap it up, these are the questions you start asking yourself if you think a spinal cord stimulator trial would be right for you. How did your pain start, right? Is this an arthritic back, and just arthritis in the back that's developed for years and years and years? I don't know if that's a damaged nerve. There's ablations for that. There's physical therapy. There's anti-inflammatories. Or did this happen, you had a back surgery, you had a pinched nerve, and it got better, but it's still a problem. Was this a traumatic event? Did you have an amputation, unfortunately, or did you have a big surgery that didn't go quite right? I mean, you start thinking of, why is the pain existing? Was there a specific nerve injured? And again, I get that it's not a cut and dry answer, right? Because you can cut on any tissue and muscle and you'll have nerve damage. So again, that's why you talk, and we kind of see what it looks like. What kind of evidence do you have on MRIs? What is the EMG shows? Do you have proof that there is a nerve injury? Sometimes it doesn't show. So where do you hurt? Right? Is this a specific spot? One leg, one foot, just the back? These are good candidates, right? We can focus on that. If the pain is all over your body every day, that's hard. That's going to be much harder to target, and I don't think a stimulator would work so hot. What does the pain feel like? Does it feel like nerve pain? Numbness, tingling, burning type pain is typically where it goes. How bad is it? Right? We talked about the more conservative treatments options like physical therapy, low-dose medications, maybe some easier, less invasive injections. If those treat your pain reasonably well, you don't need to progress to these more invasive techniques. And how does your pain affect your life? Is this affecting you every day? Is this affecting your activity? If you're not active and you're not getting around, right? We all see you gain weight. You don't, use it or lose it. Things get stiff. It gets harder and harder to make up after that deconditioning. Quality of life, sleeping, things like that all kind of start playing into it. We'll move on to some of the questions you guys had. Before I ask that, I'll just premise that essentially all the core pain docs do spinal cord stimulators, so don't feel like you have to come see me because I'm the only guy who does it. We all do them, and we're all across the valley, and they can all answer these questions just as well as I can. So I guess we'll start with a few of the questions.
Thank you, Dr. Lundberg. So just for our patients, where are your offices located?
My office is right now, I spend most of my time in Gilbert, but I do spend one day a week, and my assistant's also in Mesa, so Mesa and Gilbert. So pain medicine in general is as needed. Right? There are definitely some cases where we do schedule, but in general it's as needed. And I would love to do a trial and have my patients come back and say, I didn't need it, right? Or I used half as much pain medicine I usually do. It's always a great response. And in general, I would say you don't have to continue taking it if you're not having pain. The only caveat to that is if you are on high-dose opioids, we wouldn't want you to withdraw in the middle of your trial, and then that just kind of makes everything really messy. So certainly your doctor would come up with something to make sure that doesn't happen during your trial to eliminate that. Yeah, so sciatica is a kind of very general, broad term, right? If you herniate a disc and you hit one of your nerve roots and you're going to get sciatic pain down your leg, typically you're going to start with physical therapy, you're going to start with some easy pain medicine, maybe you do an epidural, okay, that's fine, and if that doesn't work, you'd probably be better off your MRI if it shows a disc protrusion, you're going to go to surgery and have that disc kind of cleaned up and unpinch the nerve. Now, if you still have pain in the leg afterwards, then you start thinking that nerve got damaged. and that's exactly what a spinal cord stimulator is for. Yes, yeah, these are, there's really no restrictions on activity once you have an implant placed. So the stimulator is in there, like I mentioned before, the first 3 or 4 months, I want you to live a normal life. I don't want to scare you and make you think that you can't do anything. But we tell patients just to kind of take it easy, maybe some stretching, the pain's better, and we want you to get in the gym. We want you to be active and do this, but we also don't want those leads to move. So usually about 3 to 4 months later, your doctor would tell you, hey, go enjoy life, go do whatever you want. It's just those first couple months, you just want to be reasonable about it. So there are normally 2 incisions that are made on the implant. So one incision is usually more midline in the spine. That's the incision we use to get the leads into your spinal canal and up your spine. So that incision might be anywhere from 1 to 2 inches. And then there's another incision wherever you put the battery. So the battery, they're getting smaller and thinner every year, just like everything else, but anywhere from like 2 to 3 inches. Usually horizontal, maybe in the butt, maybe the low back, somewhere in there. So there's usually 2 incisions that are made. And just like any scar, these are not large incisions. They heal relatively well. Yeah, so none of the more conservative treatments, epidurals, ablations, other steroid injections would preclude you from doing a stimulator, right? The stimulator is kind of the next step when those easier things fail. Yeah, so the leads themselves haven't changed too much in a long time. And in fact, you can switch out to different manufacturers and leave the leads in the same spot. There is a little bit of, sometimes there's an adapter or a little, nuances, but in general, you can switch them out, relatively easily. But it's all about that IPG. That's where the battery is. That's the brains of it. So sometimes these patients who come in for a battery change, they're perfectly happy, everything's fine, but it's been 10 years. It's like you just get upgraded to the newest system. Suddenly you can get your IPG reprogrammed with your company over the phone. Right? These IPGs now connect to the Wi-Fi in your house, and they can log in and they can check your system without you actually even leaving your house. And it's great. It makes things a lot easier, and you can kind of troubleshoot a lot of stuff without even coming in. But certainly you can upgrade these things, and that's a big part of the newer technologies to make sure that's possible. You can use it in the cervical spine as well. All the same basic principles apply. Certainly people have fusions in the neck and damaged nerves, so it's certainly used in both. And the battery, again, is usually tunneled a little bit longer to put in your low back, although I have seen some people have it placed kind of in the armpit area, which I guess patient preference, right? No, it is typically not visible. I always compare it to a pacemaker battery, which usually are pretty noticeable and stick out because, again, your chest wall is not that deep under your skin. But in the low back, there is a good amount of tissue, fat, and muscle back there. And usually you're putting these IPGs maybe about an inch and a half underneath the skin. So on most patients, you might be able to see the outline of it, but it's not going to affect your clothing or anything like that. I certainly have some patients who are very, very thin, and that, there's just no place to put this. It is literally, they have skin and they have muscle, and it sticks out. No one has thankfully told me to take it out because of that, but I can see it very well if you are that thin. I'd say the IPGs are maybe a 1/4 inch thin or maybe a little bit less than that. Yes, like I said, there are no restrictions. Once the implant's in, go kayak. Literally there are no restrictions at that point. We leave, like I said, the migration rate really gets low after those first few months. Yeah, no restrictions on activity whatsoever. Again, it goes back to, degenerative disc definitely can cause pain, right? It causes inflammation, swelling around the vertebral bodies. Degenerative discs are more likely to herniate and hit other nerves, but we're not quite in the area where if your surgeon said, we're sorry you have back pain, you've done all these injections, I'm not sure there's anything in there I can go, it's a 50-50, or I don't think it's the best thing for you. The spinal cord stimulator would not be, I guess, approved or indicated in that case. So you would really, hope that you can do epidurals, or possibly, you really start thinking about whether or not a surgery would be beneficial. And a lot of that gets stuck on the fact that these stimulators are not approved if you have not already had back surgery. So, if you have a damaged nerve from a trauma, or you have post-herpetic neuralgia, obviously those patients can have a stimulator and you don't need to have surgery first, because surgery would never be indicated. But when you specifically talk about the spine, neck pain, back pain, most patients are not going to have a stimulator placed if they haven't already had surgery. And that may change in the future. They're certainly kind of heading that way. Certainly to do a 7-day trial just to see if your pain is improved when you have a surgeon telling you have a 50-50 chance, and whether the pain gets better and worse seems very reasonable, and it's kind of heading that way.